Yeah, Director Vrapče, Professor Ninoslav, Professor Ninoslav Mimica. Ladies and gentlemen, I'm very happy that you have invited me from Switzerland to come here to give you a presentation. And while I listened to the previous words, I thought, yes, 140 years is also maybe the history of psychiatry as an academic discipline, which is, has developed since then in many countries. And also in my areas, we have, in Germany and in Switzerland, we have these big hospitals like yours. And so, I learned you, Nino, to know as a very brilliant organizer of a symposium. He seemed to have worked day and night, and because he sent me mails at midnight and everywhere, and he was very and he cared very much that everything worked. And so I came in time here, and I also had a wonderful driver, the best taxi driver from Croatia, who is a resident of this hospital. So everything worked quite well, and I thank you very much. I know Alexander Kurz, the previous speaker, since about 25 years. We started all in the field of dementia and discussed what might be possible. And what I saw at that time, and it started with a pseudo-dementia discussion, was that depression was always at the side. And on my academic desk, it was also always put aside with all these dementia issues. And so I started to focus a bit more on these problems, and you see now this word ment-age here. This is what I'm doing now since about 7 years, so an outpatient clinic, and ment-age is a composite of mental health and aging in Basel. And since I work in this outpatient work, I see many depressed elderly, and not so much, but also many demented patients. So I want to give a short overview and focus on some parts in this presentation. Perhaps you know these data from which have been published meanwhile 8 years ago, but they are still valid, I think. And they show the prevalence of psychiatric disorders, 12-month prevalence in Europe. And you can see anxiety disorders, which not so often come into the hospital, are the most frequent disorders. And then depression and insomnia are the second frequent disorders. And all three, that's what I'm going to show you, are much interrelated. So we have had many epidemiological discussions on the real frequency of depression in old age, and there have been concepts on fading out and on becoming chronic in any case, and this is all not true, which has been nicely shown in many studies throughout the last decades. And so we can say the majority of studies report prevalence rates of major depressive disorder at or below 2.6% in the elderly. This is slightly lower than in other age groups, but we have certain areas where depression is more frequent, and this is, for example, in the nursing homes. And in my area, people always say, okay, if you go to a nursing home, then you must become depressed. But that's not true. It's often the consequence that you go to a nursing home when you are depressed, because your social network has decreased during the years of disease. And we have incidence rates. They decreased over time, but there were no significant differences when comparing age groups. That means there has been an overview. We have not a real change over age. And what we also do not have is evidence that phenomenological differences exist among younger and older adults. This is also the discussion on male and female depression. We really have no valid data on this. So depression is the same, but what changes is that we have higher rates of depressive symptoms in the elderly. That means the symptom load increases with age. That means we have so-called subclinical depression in 10 to 50%, even depending from the setting, and we have also dysthymia. And what we also see in the elderly are bipolar disorders, and they are often not adequately diagnosed. They are often diagnosed as delirium in a manic state or in another way. So keep in mind that depression goes on or starts in old age, but often goes on throughout life, really in a similar way. What is the problem of these studies? One is that we have a higher rate of physical comorbidity in the elderly. And physical comorbidity might lead to exclusion from epidemiological studies. If you look on the study method, people say, okay, I have been, they phone people sometimes, and then they say, okay, you have depressed symptoms, have you visited a physician? And then they say yes, and he found a reason for it. It was a physical disease, but that's not true. So we have the problem with the study method. We know that the severity of depressive symptoms might be overestimated in older adults because of comorbid physical problems. So what is accounted, for example, to pain, and what is accounted for to depression. And the severity of depressive symptoms might be underestimated, for example, in the frail oldest old. So to diagnose depression in the end of life is a crucial topic. So we have many data, I fly over it in some way, on depression and comorbidities with vascular disorders, means cardiovascular and cerebrovascular disorders, with diabetes, very interesting topic, depression and diabetes, and clearly the interrelation between this depression and neurodegenerative disorders. We had a broad discussion whether it really increases the risk of Alzheimer's dementia, but it does. And depression also doubles the risk for Parkinson's disease. So something happens in the body which might pave the way for neurodegeneration. Some argue that if you grow older, you have many reasons to get depressed, so it might be a bit normal to be depressed in the elderly, but this can't be true, because all psychological data we have say that psychological factors might actually be more protective in old age. So we have not grow wise when we are older, but we are even more less impulsive. We don't keep with the negative experiences. So we have good data. That means the lowest, for example, the lowest quality of life is in the middle of life. That means with the 50s and with the 60s, and I look around, some of you are that age, and I can say the prospect is good when you get older. Some say that the stressors differ with age, so for example, bereavement might be on time, and this is also not true. It means stressors are stressors all the life, and not only when you are young or when you're old. So, what are the risk groups for depression? We clearly know that patients with a positive psychiatric history in own and family have also a higher risk to get depressed in the elderly. But we know that life events play a major role, and this is, in the young age, it's the relationship, it is financial problems. In old age, it's often the bereavement, also the relationship, but frequently also newly diagnosed diseases. We have a comorbidity with brain disorders, especially with vascular disorders. Then a comorbidity with physical disorders and disabilities, especially when they cause pain and sleep disorders. And we have new data showing that especially these chronic sleep disorders and chronic pain is also a risk factor for suicidality and suicidal thoughts. That means we have a very, regarding suicide, a risk group which is depressed, has pain, and can't sleep. Then people with missing or reduced social net, and this has led to the recommendation to perhaps check these patients in the primary care regularly for depression. Just to give you an idea that anxiety, which frequently is co-occurrent with depression, has another way through life. Interestingly, anxiety in old age is mostly an anxiety which comes up again and has started very early. That means 90% have shown first symptoms before the age of 40. And as in depression, also in anxiety, it holds true that a real newly occurring anxiety disorder or depressive disorder in old age might be a preliminary, first sign or first sign of a later developing dementia. We know that comorbidity of anxiety and depression makes prognosis worse. This has been nicely shown in the Netherlands. In the Netherlands we have many studies on depression in the elderly, and you can see that the worst outcome is in the combined group of anxiety and depression with a high rate of chronicity. There is also one public health concern which comes up, at least in my area and in some countries, that is the debate on loneliness. And it has been shown that loneliness seems to be as dangerous as smoking and overweight, and old persons feeling lonely suffer significantly more often from arterial hypertension, depressive symptoms, bad sleep, less mobility, and also dementia. That means fighting loneliness and keeping the elderly integrated into the society is a public health task of major relevance. So if we regard the differential diagnosis, I always say it is important to think of depression at all. This is the first and most important. Then to regard depression not as normal for old age. The topic of dementia and depression is difficult because these are separate disorders, but they are also in some time interrelated. The next speaker is going to talk about this a bit more in depth. From the frequency, also the differential diagnosis between depression and grief is important, and in clinical context, the differential diagnosis of depression and hypoactive delirium shall be differentiated. That means that hypoactive delirium shall not be mistaken as a depression and others. So, just one slide on depression and dementia. We know that a really major depression does not occur in dementia if it has not occurred earlier in life. That means we have other depressive symptoms in the dementia disorders and more in the vascular dementia and subcortical dementias like Parkinson's dementia than we see it in Alzheimer's dementia. If we look on the differentiation to grief, then it's relevant to understand what is grief, and that mourning is an active process. And as I show you here, that for example, from the symptomatology, low self-esteem or hopelessness, reduced emotional resonance, or even suicidality are not typical for grief. And sometimes we see patients who have had a mourning process and develop a depression in this mourning process. And then this means that they can't finalize their mourning process, it is very interesting to see that if you treat the depression of these patients, then they can continue to the morning and find an end of their grief. So, I told you that screening might be helpful. We have some screening instruments. I do not know who uses one here, GDS or something like this. In the UK, for example, it is recommended to use it especially in some risk groups. There has been a debate whether screening makes sense in national screenings, because they say, and that's true for the mental disorders, that screening alone is not enough. That means if you screen, you must have an adequate management which follows. If you have diagnosed a depression, then you should do some further assessments, and these are very important. You need information from the family, and you need information from the family physician and other specialists involved. And this is crucial. The elderly have sometimes many specialists. They have the drug pharmacists, and all, they consult all these people. And if they say the drugs you take are not good and come to you, then they say, oh, I don't want them again. And so you should communicate with, ideally with all the specialists involved. Perhaps we should start such an interdeed also for depression. You should check for medication effects, because some depression comes as a side effect, for example, with corticoid treatment and other drugs, and check for thyroid dysfunction and others. Yeah, you should take care for suicide prevention, especially in the elderly. The depression is very stronger. There's a stronger connection between depression, undiagnosed, untreated depression, and suicide than in other age groups. So why should we treat depression in old age? We have good results. We have also better outcomes of physical disorders when depression is treated. We can prevent suicide, and we can, and that's very important, preserve the autonomy of these patients. And for example, what I'm doing now to help them, that they don't get into a hospital, that they don't get into a nursing home, as long as it is possible. And there are also the more and more economical reasons. And it has been shown by various studies from the last years that the healthcare costs become 50% higher in the depressed elderly compared to non-depressed elderly. So this means we can contribute from psychiatry to health economic costs. The prognosis of depression in old age is a bit worse, but it depends from the same risk factors than in other age groups. That means it's mediated by severity of depression, it's mediated by the number of the previous episodes, which is higher in the elderly. It is mediated by chronic physical disability and by an external locus of control. This is this salutogenetic model, which is also has been also found in younger age groups. The treatment follows mostly the same rules as in other age groups. We have some modifications which we must keep in mind. We must integrate it into a treatment plan. We have more professionals involved. We have polypharmacy, so we have to take interactions into account. And the setting is important. That means, do we treat the patients in a nursing home, on a palliative care area, or where we do it. And this is especially true, or especially important for the provision of psychotherapy. What we see in many countries is that psychotherapy is not applied very much, but clearly not in the elderly. It is mostly provided in a younger, verbally competent age group and not in the elderly. But interestingly, psychotherapy studies show better results in the elderly than in the younger patients. So we should treat the elderly more with psychotherapy and less with drugs. With the biological treatments, we have a slight modification. We choose the drugs more according to the side effects and the interactions than to the previous experience. Benzodiazepines and antipsychotics shall be given only in transitory and special situations. Lithium is as effective as in younger age groups. You must check for the blood more frequently, the levels more frequently, but you can apply it. It's interesting to see that ECT is similar and even better than similar to younger age groups, and this has been nicely shown in recent studies from also from Netherlands and Belgium and from the US. I'm going to give some data on this too, and we have good data from exercise training. We have not so much time, so I skip here some slides. Regarding the lithium treatment, as I already said, we must take care of the kidney function. And now to the ECT. We have even superior responses in ECT compared to younger counterparts. It seems to be even in some cases the safest treatment option, at least with the modern methods, of ECT and modern methods of sedation and anesthesia. And it seems not to be dependent from biological comorbidities, for example, the brain damage which is pre-existing. For the psychotherapy, we have all the methods which have been developed, like in the younger age groups. We have not many data, interestingly, on body-oriented therapies, just on relaxation techniques, but no other methods have been studied. We have the best empirical evidence for CBT, for interpersonal therapy, which has also a late life version, for the problem-solving training, and for life review techniques, which can be applied. I frequently work with life review techniques. I love them very much. So, at the end, I want to give you 2 slides on prevention, because I think prevention is if it's possible, and it is possible in depression, we should try to do it. We know that prevention, general prevention, is not so efficacious. So that means these, if you make a program with media and everything, it's not so much efficacious. But prevention in high-risk groups or in subthreshold depressed patients are very effective. And there we have seen that the incidence of depression might be reduced by 25 to 50%. This is in general, and there has been a nice study from the Netherlands, which even did a follow-up after 1 year, and they could show that the depression could be reduced by 50%, which meant a number needed to treat of 5. This is very, very effective method. and it has done with patients over the age of 80. So it's really an old age psychiatric study. I come to the conclusion. I hope I have given these messages to you, and I want to advertise a bit for the next conference of the European Psychiatric Association at the end of March in Madrid, 2020. Who of you likes to go to Madrid or always wanted to visit the Prado should come to this conference. So, thank you.